When I was first diagnosed with CLL, my doctor told me straight up that I was going to die in about 6 years. And that doctor got fired. My next doctor told me, don't worry, we've got this. You might die with this, but you're not going to die from this.
I'm Michele Nadeem-Baker. I'm a medical and health journalist, but in addition to that, I am also a CLL patient. And I started advocating for other patients my first day of treatment when I realized that there's just so much unknown there, and to demystify things for my fellow patients and help them through their journey.
My name's Jeff Folloder. I am a passionate patient advocate. I am now in year 14 of my little journey with CLL, and I am living a great life. And that's why I became a patient advocate, because I want to make sure that everyone knows that it is possible to live a great life with CLL. First up, I get to introduce Dr. Catherine Coombs. She is a hematologist oncologist with UCI Health, and she specializes in chronic lymphocytic leukemia. She also helps lead clinical trials, trying to find better ways to treat CLL.
And I'd also like to introduce Dr. Yair Levy, who is a hematologist oncologist at Texas Oncology. He is the director of hematologic malignancies research and specializes in CLL. He's also helped lead clinical trials in CLL.
We have an interesting topic for today's program: shared treatment decision making, how to be an empowered CLL patient. This is something that strikes me right in my heart. I am a firm believer that patients who take an active role in their own care tend to have better outcomes. And this is actually borne out by clinical research. I took an active role in my own care. I chose not to go in a specific direction that my first doctor wanted to go in. And I wound up at a large research hospital and wound up participating in a clinical trial. I've been living a great life as a result.
So for me, treatment decision making also came down to becoming an empowered patient and becoming health literate in CLL. So the more I could learn from credible sources, for me, what was better. I realize all patients are different, and doctors, you can probably relate to this more than anyone. But the world of CLL has changed quickly and pretty drastically for clinicians, researchers, and those of us who are patients. For myself, I was diagnosed 11 years ago. Not quite as long ago as Jeff, but, still a long time ago. So it seems. And my frontline treatment started in 2015, and things were even different back then. I was on a trial that combined ibrutinib, which at the time was not approved yet for frontline treatment. It had been for relapsed and refractory, but not frontline treatment. And it was combined with FCR, the standard at the time, fludarabine, cyclophosphamide, and rituximab. So uh, things have just changed so quickly, even since then. In my frontline treatment, I'm now on a different treatment. I had relapsed in between. But Dr. Coombs, could you tell us how the landscape of treatments for CLL patients has vastly changed over the last couple of years?
Yeah, I mean, there are a couple different conversations I thought you were going to ask over the past decade. But even over the past few years, we're seeing advances. So when I first got into, the CLL field, yes, it was chemoimmunotherapy for the patients fit enough to receive it, like FCR, BR. And so with the introduction of targeted agents, largely chemoimmunotherapy is not widely used, though we still do see about a third of uptake, um, and looking at kind of these large scale studies across the country. But I'd say that docs who are focused on CLL, we realize that chemoimmunotherapy is not worth the toxicity, given that its efficacy is also inferior to these novel drugs that are, number one, more efficacious, so more likely to, put the CLL at bay, in remission, and delay time until ultimate progression, but also just hugely safer. And so that was first ibrutinib, as you very wisely know about from your own personal experience, and of course your knowledge over the time of your journey as a patient. But now we have a lot of kind of even newer and better drugs. And so ibrutinib has been amazing, revolutionary, but it does have some side effects. Fortunately, they're not so common, but they still can be clinically significant. And so the first category of drugs that have really changed in the past few years are newer generation BTK inhibitors. And so ibrutinib was the first in class. It inhibits this, critical protein that's part of CLL cell machinery, BTK, but it's not totally selective for its target. And so we now have two additional drugs that inhibit BTK, acalabrutinib, and then the most recent addition is zanubrutinib, which was FDA approved in January. And the advantage of both of these drugs are that they're more selective for their target, BTK, and that fortunately has translated to improved safety, where both drugs have been compared head-to-head with ibrutinib, and they demonstrate improved tolerability, specifically lower rates of atrial fibrillation for both drugs, and then acalabrutinib also has the advantage of lower rates of hypertension. What we don't know is whether zanubrutinib is better than acala or acala better than zanu, because we don't have that comparison, but I think they're both excellent options and both offer advantages over the ibrutinib days when we were dealing with a lot of atrial fibrillation. There's a lot less in the way of that. The other huge class of drug that I haven't mentioned is just a completely different way of treating CLL. And so I'll just mention it briefly. I don't know if we're going to get more into the nitty gritty on this, but these BTK inhibitors work wonderfully at controlling CLL, but they're considered as treat to progression regimens, meaning that patients go on and stay on as long as they're, number one, tolerating it, and two, their CLL is responding favorably. Some patients don't like the idea of being on a drug indefinitely. And so the other huge therapeutic advance over the past few years that's been widely available is the drug venetoclax. So this is typically combined with another drug called obinutuzumab when used in the frontline setting. And because it can so effectively kill off the CLL to very deep levels, patients are able to completely stop treatment after 1 year. And then eventually they relapse, but it can take a long time. And so that's one of the other major changes in CLL just over these past 5 years or so.
So I think Dr. Coombs, hit the nail on the head. So, it's a dramatic change from chemoimmunotherapy. So in the chemoimmunotherapy era, our high unmet need was what we considered high-risk CLL, which was ones that harbor a 17p deletion or a mutation in this TP53 tumor suppressor protein, or these cells of origin that are what are called pre-germinal cell of origin. So a more immature cell that had gone bad. And we've known that they have done historically quite poorly with chemoimmunotherapy. So as Dr. Coombs mentioned, the biggest improvement that we saw was when we actually recognized druggable targets within the B-cell receptor pathway. And, the first such drugs were actually not the Bruton's tyrosine kinase inhibitors, and they're largely relegated to the history of the B-cell receptor pathway now. But these were the PI3K delta inhibitors, right? So those worked irrespective of cell of origin, and they also worked in this 17p deletion. So again, they did certainly had some tolerability issues, and the efficacy was not comparable to those of the Bruton's tyrosine kinase inhibitors, which is one of the big reasons that those have really fallen out of favor. But then, as Dr. Coombs mentioned, the BCL2 inhibitor venetoclax has also been a game changer. And we've been utilizing these agents, either alone or in combination with CD20 monoclonal antibodies. And, now in the European Medical Association, they've even approved the combination of a BCL2 and a BTKI. And, this is something that we're doing further studies with in the United States as well, because we're seeing that people achieve very, very impressively high rates of response. And more importantly, very, very deep responses that, can allow hopefully a very long treatment-free interval and perhaps even in some cases a functional cure. So in the beginning, we were saying that CLL is largely treatable but incurable, but we put an asterisk by that. So even with chemoimmunotherapy, there was a subset of CLL that may have been cured by chemoimmunotherapy, or at least a functional cure. And I think we're going to see the same thing with these other combinations as well.
So we've been talking about a whole bunch of novel therapies, stuff that has really impressive outcomes these days. Michele and I will both be able to tell you without hesitation, the first thing that most CLL patients encounter is not treatment. It's this thing that we call watch and worry. You guys call it watch and wait. Um, CLL does not always need to be treated right away. Your medical team is going to work with you to decide when it's best to start treatment. In the meantime, the patients worry. Did I sum that up correctly, Michele?
We sure do, even though we tell everyone not to and to take a breath, when they're first diagnosed. Jeff, you and I both know that we still go through that when we're back in that time period. And it's just so counterintuitive to not be treated right away, right? When the disease has not progressed where it ends up going when you do get treated. But, Dr. Coombs, what are you looking for, for when it's time to treat? So we've been, you go through years, hopefully, during watch and wait, worry and wait, as patients call it. But what is it that you're looking for? And is there any benefit to treating it sooner, as with some of the other cancers out there?
Yeah. So, I'm coming straight from my clinic. I'm in a clinic room. I just had this conversation with a patient who is newly diagnosed about watchful waiting, which I totally understand why it's watchful worrying for many. I always see it as my duty to help them understand why this is our approach. And I acknowledge this is not what we do for many other cancers, where you hear find it early, treat it early. I wish our treatments were so good that treating it early would, knock it out and you'd never have to worry about it again. But, in 2023, we haven't been smart enough to come up with something that'll do that for CLL. And the way that I help put that in context for my patients is, the first fact of the matter is this disease can be so indolent that maybe up to 1 in 3 patients never need treatment in their lifetime. So if we treated everyone, inherently we're over treating people. And I hate giving people things they don't need, because every treatment comes with cost, whether it's financial or side effects. So that's my one very strong argument for not over treating. But two, none of the early treatments that we have tried in, well done clinical trials have shown to make patients live any longer. And so that is just where we are. And I definitely could understand frustration on the part of patients, because that just leaves you with, these worries. I do see those getting better in patients as time goes on. There's this initial period of uncertainty, but then as you see kind of what your CLL's pattern is, that kind of either tells us, well, maybe we are approaching the time for therapy, or gosh, nothing's really changing and I feel fine, and this is something I can just kind of accept. Now, obviously, we never know which camp a patient is going to fall in, and these prognostic tests kind of help us have a general sense of maybe this will be a super slow CLL versus maybe one that progresses more rapidly, but nothing is certain. I do personally have enthusiasm for making this change. There is an ongoing countrywide clinical trial looking at early intervention for patients with high-risk CLL that is, of course, open at my own institution, but across many, many institutions in the country. And so, I really hope things will change where we can, improve patients with early disease, but I don't think it's going to be every patient, because again, because of this almost third that never needs treatment, I don't ever see a reason to just treat everyone. But the trial specifically is focusing on high risk patients, and so maybe there will be some movement there. It'll
So, I completely understand, the anxiety that comes along with this. I mean, I've been treating indolent lymphomas for a couple decades now, and I've got the same experience. You talk with patients, you tell them they have a cancer, and then they're saying, "Well, you tell me I have a cancer, but you're not going to treat me now. Are you sure you went to medical school?" And I've had that come up several times, and I completely understand. So, as a result, by the way, we don't do watchful waiting anymore. We call it active surveillance. So nobody likes watchful waiting, but if we're saying we're actively surveilling you, that sounds certainly a lot better. But the way that I explain it is I say there's really only two good reasons to treat you for anything, right? And this isn't just an oncologist, this is in all of medicine. So my wife is a real doctor, she's an internist. And, she has the same parameters for treatment, right? So number one, if you can make somebody feel better, that's absolutely a great reason to treat them. And number two, if you can make them live longer. And what we've seen, as Dr. Coombs was saying, in chronic lymphocytic leukemia, as well as a variety of other indolent non-Hodgkin's lymphomas, is, early treatment does not confer a benefit in survival. In other words, if we treat you when you're asymptomatic, you're not going to live any longer than if we wait to treat you when you are symptomatic. And this is important because, as we were talking before, our treatments are changing and changing for the better. So, the treatments are becoming more effective and better tolerated. And remember, something is only incurable until we're able to cure it, right? So waiting, there's a lot of good reasons to wait. And, Dr. Coombs was mentioning this as well. So if I can't make you live longer by treating you earlier with our current therapeutics, right, the question is, can I make you feel better? And if you're asymptomatic, I can't make you feel better. I can make you feel worse. I can spend a lot of your money, but I'm not helping you, right? And again, you are, the most important part of that equation. So it's a very long answer to your question, right? So if somebody has liver involvement, liver enlargement, the question is, are they symptomatic, right? Are they having pain? Are they having, any other symptoms from their liver involvement? And if they're asymptomatic, I would not necessarily treat just for liver enlargement, right? And the same thing is true with spleen enlargement as well, which is a far more common finding in chronic lymphocytic leukemia.
So, Dr. Levy, let's break down what those current treatments are, what baskets they fall into, and the versus thing. Is this a lifetime activity, or could we end it in 6 months? Could we end it in 1 year? You've got a lot of stuff that ends in IBS and TUS and MABs and all that. Explain to us what's going on.
Yeah, so again, this treatment to progression model is a relatively new phenomenon for us in the treatment of heme malignancies. So we used to treat with fixed duration of therapy when all we had was chemoimmunotherapy, and you can obviously understand why, right? Once we give chemo, we can't take it back, and certainly the effects of cytotoxic chemotherapy are not something that you want in a cumulative manner. So, just by the logistics of how cytotoxic chemotherapy works, we could not give that till progression because that would be a very difficult life. Everybody thinks that the worst thing in the world is dying, and no, the worst thing in the world is not dying. The worst thing is a long, crappy life, and that's what we would assure we would do to people if we continued them on chemoimmunotherapy. But if you take a look at our approved therapies right now, basically it's two categories, right? Bruton's tyrosine kinase inhibition, as well as BCL2 inhibitors. And obviously monoclonal antibodies can be sprinkled on any of these regimens. And in terms of approved fixed durations of therapy, right, it's only with the BCL2 inhibitors. And the reason for that is that's the most cidal drug that we have seen in the treatment of chronic lymphocytic leukemia. And what I mean by that is it is a killing machine, right? It kills so well that it killed so well that we had to attenuate the dose, because if you kill things too quickly, that can also become a problem. So we're able to get those very, very deep responses. But as we know, these deep responses, even if they're what's called MRD, which stands for minimal residual disease, but really should be measurable residual disease, right? So even if people achieve a level of disease below where we can measure it, we know that in many cases, it still returns. So we really need to get that logarithmic killing. We really need to reduce their tumor burden, by many zeros in order to give them that long treatment-free interval. And currently, that's possible more likely with a BCL2 inhibitor, venetoclax. And as we were alluding to before, we are seeing combinations of Bruton's tyrosine kinase inhibitors like ibrutinib or acalabrutinib or zanubrutinib in combination with venetoclax. Again, this was based on these laboratory models in which they actually saw whether or not these cells were primed for death with this combination. And they actually saw synergy, meaning that the drugs worked better together, right, than the sum of their parts. And as we mentioned, this is a fixed duration of therapy that's actually approved in Europe right now, but not here in the United States. So in the United States, we certainly can give fixed duration of therapy with venetoclax and a CD20 monoclonal. And I can tell you that anecdotally, I've also done that with a Bruton's tyrosine kinase inhibitor and a monoclonal if I can achieve that very deep response.
I am on acalabrutinib and was on obinutuzumab until a couple of weeks ago. It was obinutuzumab, otherwise known as Gazyva, for our audience, for 6 months, along with acalabrutinib. And now I will be staying on acalabrutinib indefinitely because I am considered high risk. Now, I had originally stated before that I started on ibrutinib. BTK inhibitors work for me. And I just had adverse events initially, and that's why I went off. So I had a couple of years of a drug holiday, and then my doctor decided that while BTK inhibitors were still working, let's go for it. So I would still have another option with venetoclax. Dr. Levy, why does a monoclonal antibody help? What does it add to the 1-2 punch? I know you talked about the different things that they're addressing and being a killing machine, but why is it only for some patients, especially, for example, what I'm on, acalabrutinib and obinutuzumab trials have shown that it specifically works the best. One trial that was presented at ASH this past year for people like me who are unmutated. So why only for some patients is it a benefit?
Well, that's a great question. So, the CD20 monoclonals were obviously our first immunotherapy in the treatment of many B-cell malignancies. And when we combine them with some of the targeted therapies, we didn't necessarily see what we were expecting. So in all of the trials with chemoimmunotherapy, adding a CD20 monoclonal improved progression-free survival. But interestingly, when we took a look at some of the studies that had arms that contained both ibrutinib, our first covalent Bruton's tyrosine kinase inhibitor, in combination with a CD20 monoclonal or without, those progression-free survival curves were superimposable. And I think we were really surprised by that. But by the way, I need like a button that says I agree with Dr. Coombs. So Dr. Coombs was actually mentioning the fact that, there is differences among these covalent Bruton's tyrosine kinase inhibitors. And our first one had a less focused kinase profile. In other words, it hit other kinases, not just Bruton's tyrosine kinase that we were trying to inhibit. And one of the other kinases that it inhibited was something called ITK, or inducible tyrosine kinase. And this led to antagonism of the CD20 monoclonal, which is why we got no benefit from the addition of the CD20 monoclonal. Now, this is not true for the other covalent BTKIs, Xanu and Acala. However, you're seeing the combination with Acala because that is FDA approved, and zanubrutinib does not have an FDA label in combination with a CD20 monoclonal. Do I have any reason to think that it wouldn't work as well? I do not, and there's certainly data that supports that as well, that there are differences in terms of, PFS for folks receiving the combination of Xanu with a CD20 as well as without. Now, you can say, so why doesn't everybody get a CD20 monoclonal? And the answer is, there are trade-offs, right? So everything in life is a risk-benefit ratio. And we know that, for example, there is this virus here in Texas, I don't know if you guys have it too, called COVID. And we know that for COVID, the CD20 monoclonals certainly antagonize an immune response to vaccination, as do the BCL2s and the Bruton's tyrosine kinase inhibitors. But certainly you are at more risk for adverse events and complications when you add additional drugs, right? So everything is a trade-off, right? We're getting additional efficacy, but at a cost. And our job is not to tell patients what to do. Our job is to have a discussion and come up with a solution that works best for them after we have a discussion and they are fully informed.
Sometimes patients are told that they need to switch out their BTK inhibitor. There are a lot of reasons why this could be done. Dr. Coombs, can you tell us what's going on with this?
Absolutely. So that is a common question. And that's something that's evolved over the years of having, one option, just ibrutinib, to now having multiple options. So in my own practice, I actually have switched patients for a number of reasons. I would say the reason that I consider switching a patient off of a BTK inhibitor to a different BTK inhibitor is if they're having some side effect that's negatively impacting their quality of life. And so I have switched patients from ibrutinib to acalabrutinib with very good success. I've also switched patients from ibrutinib to zanubrutinib, and I've even switched patients from acalabrutinib to zanubrutinib. There have been studies looking at switching for side effects, and about 70% of the time, the patients have improved tolerability on one of the newer drugs. And so there have been studies looking at switching to both acala from ibrutinib and then switching to Xanu from both ibrutinib and acala. And that seems to be pretty uniform result, where more often than not, the newer drugs are better tolerated than, our oldest drug, specifically ibrutinib. So I think that's a very valid reason to switch. The education point is I would not switch in the setting of progression. That just is not a strategy that works more than a month or two, and it isn't really worth it. And so if you're progressing on a BTK inhibitor of these FDA approved ones, again, not speaking to pirtobrutinib, switching from any of the approved ones, ibrutinib, acala, Xanu, that is not recommended. Now, I've heard of some occasional doctors just switching everyone off of ibrutinib. I'd say, I talk to a lot of the CLL community. I think most of us don't do that because the side effects that occur most of the time are early on. So I don't use ibrutinib for my new starts, but I definitely have patients in my clinic who have been on it for years and they're doing well. And, the old expression is, if it ain't broke, don't fix it. Some people think, well, let's just switch everyone. I don't think that's wrong, but it's just not something that I've done for the reason I mentioned.
Thank you. Dr. Coombs, let's talk about ramping up treatment. When you start treatments such as with venetoclax or even obinutuzumab, you start with smaller amounts and then ramp up to full dosing. Why is that?
So it's different based on the drug. So let's tackle obinutuzumab first. So obinutuzumab, or Gazyva is the brand name, is the monoclonal antibody that can be paired with either venetoclax or acalabrutinib. It can also be used by itself less often. It's a hugely effective drug, but it doesn't really have that many side effects, except for one that's almost universal, which is these infusion-related reactions. So, of course, it has other side effects, such as the impaired vaccine efficacy, infections. It can cause low blood counts. But the one that's like universal is infusion-related reactions. So what they've learned over the course of, developing this drug in clinical trials is that instead of just kind of blasting patients with the full dose on the first day, the reactions seem to be more manageable if you split the dose. And so the traditional way of administering obinutuzumab, the full dose is 1,000 milligrams instead of doing that all at once, which would make for a very colorful reaction in the infusion suite that no one, nurse nor patient, wants to be involved with, is giving 100 milligrams day one and then the other 900 day two. And then, of course, you follow along with the rest of the schedule. The reactions, fortunately, are almost always on the first 1 or 2 days, and then not long lasting, except for, rare exception. So that's the reason for kind of ramping up obinutuzumab, is to make the reactions more manageable. Venetoclax is a different story. And so just like Dr. Levy mentioned, this drug is just remarkably effective at annihilating CLL cells. But it's not a good idea to kill any cancer just too quickly, because when you kill a cancer cell, all this dead cancer cell debris gets released into our bloodstream, and our kidneys can't handle that, even the best kidney in the world. And so instead of killing the cancer rapidly by administering the full dose, it's been learned through very well thought out and designed clinical trials that patients tolerate it better with less chance for dangerous tumor lysis syndrome, which is the term when we get complications from a cancer dying too quickly, is to ramp it up. And so instead of just giving patients their full dose of 400 milligrams daily, we give them a little whiff of venetoclax week 1, 20 milligrams, a little whiff the next week, 50, and kind of slowly introduce. So we're more slowly killing off the CLL cells in a way that's friendly to the kidney, friendly to the rest of the body, to minimize any potential risk from all this dead cancer cell debris.
Doctors, there are so many types of treatment in clinical trials. Dr. Coombs, which ones are you most excited about that are getting closer to FDA approval potentially?
There are 2 that I'm going to mention. I'm excited about a lot of things, but the ones that I think are the closest to being approved, potentially, I have no window into when the FDA actually approves things. One is this drug called pirtobrutinib. So this is a drug that inhibits the same target as ibrutinib, acalabrutinib, zanubrutinib, BTK, but instead of inhibiting it irreversibly, it is a reversible inhibitor. And the reason that that's important is that when patients develop resistance to the ibrutinib, acala, xanu, the resistance is shared by all of these drugs. And so you can't switch from acala to xanu or ibrutinib to xanu, et cetera, if your patient is resistant, because they develop most commonly mutations where the drugs bind. So Perto binds at a different mechanism. It's just in a different part of the BTK molecule protein. And it has shown very excellent efficacy in a very large study. And so I do think that that may attain FDA approval for CLL in the coming days. It's already FDA approved for mantle cell lymphoma as of January. So there are ways to kind of get it off label. But I would much rather see it get full FDA approval to help with insurance paying for the drug when it's needed. But it fills a huge unmet need for patients who have progressed on covalent BTKIs, and especially after patients who have progressed following venetoclax, where we don't really have good options. The other big category that Dr. Levy has alluded to is the combination of a BTKI plus venetoclax. So Europe approved the combination of ibrutinib with venetoclax. That did not get approved in the United States. And I can't really speak towards the reasons because I'm not involved with those discussions. I do wonder if some of it may be the toxicity of that regimen, which can be somewhat hard to tolerate, especially for older adults. What we know is that we have better BTK inhibitors with respect to tolerability. And so there are a couple trials that are looking at the combination of acalabrutinib and venetoclax that I do think hopefully will be positive trials that lead to FDA approval. So that's the other kind of major category that I'm looking forward to. And those would be frontline treatment. So you would use that combination as your first treatment, whereas pirtobrutinib, if it gets approved, it would be a relapse treatment. At least for now, things obviously change as time goes on.
I told you I need that stamp, so I agree once again with Dr. Coombs, right? There's obviously other small molecule inhibitors, again, targeting that B cell receptor pathway, which has really revolutionized the way that we treat a lot of these B cell NHLs. In addition, the bispecifics, which are certainly working their way into, our armamentarium for non-Hodgkin's lymphomas, as well as CAR Ts. So, interestingly, one of the first articles that came out about CAR T was in chronic lymphocytic leukemia, despite the fact that, our current constructs, these, current autologous derived products are certainly not showing the same level of efficacy in chronic lymphocytic leukemia as they are in diffuse large B cell lymphoma, for example. But nevertheless, I think that we are going to see some tremendous improvements in terms of the CAR Ts in chronic lymphocytic leukemia, as well as the bispecifics.
Dr. Coombs, what can patients and their caregivers do or ask if their local hematologist oncologist isn't quite looking at this new wonderful stuff that's on the plate right now? What if they're just going with the old stuff?
That's such an important question. And if your doctor is not sounding, up to date, or if you're just not getting your questions answered, then you deserve more than that. And I just think it's so important to advocate for yourself, or advocate for your loved ones if things just aren't adding up. I think our community docs are amazing. The ones that I interact with, I literally have no idea how they keep up with everything they keep up with. But to put things into context, there's around 20,000 cases of CLL diagnosed a year. When you think about the common cancers that are, the majority of the patients they're seeing, lung cancer, breast cancer, those are like 200,000 plus cases. And so CLL ends up just being a much smaller slice of what they're seeing every day. And it's just very hard to keep up. And I would say most community docs I work with very much welcome the second opinion, because I can teach them something and then we now have a relationship where they'll, ask me questions and we can just work together. And so number one, don't be worried about offending your doctor. Number two, most doctors aren't going to be offended. And sometimes it's just good to hear things twice. And so I think if your doctor is offended, that's a red flag on their own ego.
Thank you for that. And I love the way you put it. Patients should not be concerned about asking questions. They shouldn't be concerned about saying, why not? And if they're having trouble getting along with their doctor, like you said, that's a red flag.
Couldn't agree with you both more on that.
What is the single most important thing that you want patients and their caregivers to take away from this discussion?
It's going to be hard to narrow down one thing, but I think if I have to say one thing, it's there is hope. Leukemia is a horrifically scary word to hear for the first time, or maybe even after years of knowing that this is what you have. But CLL, the treatments work extremely well, and they work for an extremely long time. And there is hope to live a normal life, hope to see your kids, your grandkids grow up, and so there's always hope on the horizon, in my opinion.
We're doing so much better. As I mentioned in the beginning of the conversation, I have not had a patient die of CLL in the past decade. And when we take a look at the high unmet need, and again, Dr. Coombs was alluding to that. So folks who have progressed on a Bruton's tyrosine kinase inhibitor and a BCL2 inhibitor are certainly the unmet need. And we have a tough time finding those folks. So we've had some CAR T studies that have been languishing for accrual because it required for folks to become double refractory. And again, we have a tough time finding those patients, which is wonderful, right? I don't want to find those patients. I put 2 people on in the past 5 years, and one of them was actually not even really refractory. He just wasn't taking his medication. And, with CAR T, once I give it to him, he can't untake it. So this was more of just me being paternalistic.
So I agree. Some of my key takeaways are that there are so many things in research, and we have the potential of ibrutinib being approved in the somewhat near future, which is yet another option for us. And that, as you had explained, it does work in a different way than the traditional types of BTK inhibitors we now have. I think this is fabulous to have yet another option for patients. It's been so great hearing you and Dr. Coombs and Dr. Levy both talk about things about patients asking questions and you encouraging it so that patients are not afraid of this.
Listening to both of you fantastic doctors talk about the landscape of CLL and even use that 4-letter word, cure, I am convinced that I am going to be able to continue doing everything that I want to do. And I want to do an awful lot of things. At some point, if my daughters are cooperative, yeah, maybe I'll become a grandfather. But I'm going to continue knocking out half marathons. I'm going to continue knocking out full marathons. I'm going to drink good wine and good whiskey. I'm going to eat well. I'm going to laugh a lot. I'm going to smile a lot. And I'm going to share my story so that patients and their caregivers know that that can be their life too.